przycisk nagrywanie i już przekazuję głos pani doktor Laskiewicz. Już w tej chwili bardzo proszę, można mówić.
Witam wszystkich koleżanki, kolegów i gości. Cieszę się, że nas tyle bierze udział. Niestety znowu na Zoomie, a nie możemy być razem osobiście, ale przynajmniej dzięki naszemu sekretarzowi Tomkowi możemy się spotkać przy tej nowoczesnej technologii. I bardzo serdecznie witam między nami właśnie naszą dzisiejszą prelegentkę Agnieszkę Michael, która jest onkologiem w Royal Surrey County Hospital w Guildford i reader in Oncology na Uniwersytecie w Surrey. Więc nie będę zajmowała więcej czasu, bo Agnieszka ma bardzo ciekawy temat, więc bardzo proszę, Agnieszko, rozpocznij.
Dziękuję bardzo Pani Bożeno, dziękuję Tomek i dziękuję za zaproszenie. Tak jak wszyscy moi poprzednicy, dam krótkie przedstawienie po polsku, a potem przestawimy się na język angielski. Tak jak Pani Bożena powiedziała, jestem onkologiem, Akademię Medyczną skończyłam we Wrocławiu i przyjechałam od razu po stażu. I zainteresowanie immunologią zaczęło się w zasadzie w czasie pracy naukowej. Robiłam doktorat badając szczepienia na raka piersi i ten temat immunologii i nowych metod leczenia stał się dla mnie bardzo bliski. Ja teraz zrobię screen share. Czy wszyscy widzą?
Nie, już teraz, dobrze.
So once again, thank you. The title of my talk is about cancer immunotherapy. Are we closer to curing cancer? And I would be really interested to hear whether at the end of that talk, you feel the same as I do, that we actually are closer to curing cancer. We're not quite there yet, but I really believe that we are getting closer. And the reason why we say that is because even before, when I started oncology as a specialty, and that was 12 years ago, well, 12 years ago as a consultant, many years before in training, the concept of curing cancer or curing metastatic disease was really not something that many oncologists believed in. There were maybe 2 or 3 cancers that we could cure from the metastatic state. So for example, testicular cancer or obviously some of the hematological malignancies. But the solid tumors like lung cancer, like melanoma, really were the killers. They were often diagnosed at a late stage, or when they came back, that was it basically. And even though people were living longer, the concept of cure was not seriously thought of. Sorry, I'm just scrolling down. Okay. So the landscape in treatment of cancer has certainly changed, and I'm not going to talk about any of the well-known methods of treating the cancer. So surgery still remains a mainstem of treatment. If we can cut it out, we do. And in early cancers, this is a method of curing cancer. We're obviously still using chemotherapy, we're using radiotherapy. A new type of treatment that has come in the last 10 years is targeted therapy. So rather than attacking cancer cells' DNA and giving a sort of damaging any cells that proliferate, we now are able to target treatment to a particular pathway within the cancer cells. And if you can see here on that little graph, I'm not going to go through it in detail, but what we're able to do with this targeted therapy is attack a particular type of enzyme or particular type of reaction with targeted therapy. So this really has been a revolution in cancer treatment as well. But in addition to that, we've got the immunotherapy. And for many, many years, we talked about cancer vaccines, antibodies. I think most of you are familiar with antibodies and cancer. But the true revolution came with so-called checkpoint inhibitors, and that's really what we will focus on. It's always worth to talk a little bit before we talk about the developments in immunotherapy nowadays. It's always worth talking a little bit about the history. So the concept of treating cancer with immunotherapy is not a new concept. It goes back to 1890s to an American surgeon called William Coley, who first observed and then experimented with trying to treat cancer with bacterial toxin. He basically described a case of his patient with sarcoma, who, when she developed a very severe infection with developed erysipelas, he noticed that some of the sarcoma has actually regressed. And he then experimented for years and developed this toxin called Colles toxin, which was a mixture of sort of live and dead Streptococcus and Serratia, and was trying, not very successfully, but in some cases successfully, to treat cancer with that. And then for many years, up until the sort of 1960s, people have not talked again about the immunotherapy for cancer. In 1960s, there was a Nobel Prize for Frank Burnett, who came up with this sort of acquired immune tolerance theory. So he was trying to explain, why is it that if we have a fully functional immune system, that our immune system allows the cancer cell to grow. We're able to spot the viruses, we're able to spot the bacteria, we're able to fight them, but yet we can't fight the cancer. And he sort of started this theory and scientific research that somehow our immune system stops seeing the cancer because the immune cells acquire tolerance to cancer cells. And then after that, it's been many years, up until the last sort of 20 years, where the development of immunotherapy as a means of cancer treatment has really taken on. It's always worth to talk a little bit about the basics of immunotherapy. So I'm just going to show you this complicated immunotherapy cycle, but really just to understand that on each stage of that immunotherapy cycle, we can intervene, and this intervention may be more or less successful. So starting from the sort of, if you think that all those gray cells are cancer cells, starting from number one, so cancer cells, in order to be seen by the immune system, need to have a lot of cancer antigens. So same way as the virus, as we all hear about the virus and the vaccine that is being designed for the coronavirus, which is designed against the spike protein. In a similar way, the cancer, in order to design, whether it's a vaccine or any other targeted immunotherapy treatment against cancer, we need to have an antigen. So those antigens are contained in the cancer cells. They can be released. So some of the cancers will express the antigens on the surface of the cells. Other antigens need to be released by destroying the cancer cell. And once those antigens and the proteins are released, then they can be translated and sort of presented to the immune system. So the second step in that sort of immune cycle is that antigen can be presented, and that's again done by specialized cells in the body, and those cells are usually dendritic cells, or so-called antigen presenting cells. They're taken up and translated to the immune cells. It's a special language, and the immune cells pick up this signal and then start a sort of cascade of producing immune cells. And then those immune cells need to be released, and then they need to travel to the tumor. So it is, as you can see, it's many steps of a very complicated process that at each step can be made easier or difficult depending on what happens within our organism. So for example, some of the tumors that we have may have a lot of antigens, others can have no antigens, so they're not visible. Then you can have a lot of antigen presenting cells in the body, or you can increase the numbers of them. On the other hand, you can have very few of them. You can have well-functioning immune system, or else you can have a dampened immune system response because, for example, you've just had chemotherapy and there are no white cells in the body at all. Then the circulation of the immune cells that go into the tumor, again, you can have tumors that are infiltrated with blood vessels and they get easy access, so that the immune cells get easy access to the tumor, and you see tumors that have a lot of tumor infiltrating lymphocytes, for example, and then you will see tumors where you have no white cells at all in the surrounding. So the trafficking here can be better or worse depending on the type of tumor and the type of immune environment. And then again, the tumor recognition can vary depending on the type of tumor, and again, depending on the immune system response. And I'm not going to go through any of those treatments here, but again, it's just a demonstration that each one of those steps in the immunotherapy or immune cycle in the body can be influenced. So as I said, with the antigens, they can be released by using chemotherapy, radiotherapy, targeted therapy, so any means of destroying cancer cells to release the antigens outside. Then the antigen presentation can be improved by using vaccines or other types of immune interventions. The so-called priming and activation of the immune cells, again, can be improved by this whole new range of treatments, which we'll come back to. The trafficking to the tumors can be improved by using, for example, antibodies such as anti-VEGF, so various sort of treatments that will improve the circulation and improve the access to the tumor. And then the recognition and killing of the cancer cells can also be improved. But this, you know, this complexity and the number of different ways that the immune system can be modulated has been a topic of extensive research over many, many years. And it's taken many years to actually get to the point where we now can use some of those immune treatments successfully. So a little bit about the cancer vaccines. The reason why I talk about it is because this is what my own research was about. Not particularly successful. Having said that, we do now have a cancer vaccine that has been approved by the FDA, FDA being the sort of American licensing authority. We can use it in England as well, but it's not NICE approved. And it's the first vaccine for prostate cancer. So vaccines, when you use them, the whole concept of using a vaccine in cancer treatment is that if you accept the fact that the immune system has become blind to the cancer antigen and doesn't recognize it anymore, and then if you inject the same antigen in a different place, close, for example, to a lymph node, and you start a sort of new local immune response, you can again sensitize the immune system to the same antigen by sort of external booster of the vaccine. So over the years, people have tried different means of doing that. So they injected proteins, for example, or whole or DNA vaccines. DNA vaccines would work on the basis that you inject the DNA and you wait for the body to then translate it into the protein, and then that protein is presented to the immune system to be recognized. And once it's recognized, then those immune cells can travel to the tumor elsewhere to kill it. We've used whole cell vaccines, for example. I remember not that long ago using irradiated prostate cancer cells. So they were irradiated in order to stop them from dividing, but they were still live in order to start the immune response given to patients with prostate cancer to see whether that can fight the cancer. Dendritic cell vaccines have been very popular. So these are the antigen presenting cells, again, given to people in order to get the immune system more active in terms of translating the message that the tumor gives to the immune system. And there continues to be a lot of research on various viral-based vaccines, and some of them are very successful. The vaccine that has actually been approved, it's a vaccine that relies on taking the cells away from our own, from the cancer patient's body, then pulsing those cells with an antigen outside in the laboratory, and then putting those cells back in. And that vaccine is currently in use, and it is a successful cancer treatment. Everybody's familiar with antibody treatments. I mean, there's a whole range of different antibodies that target specific antigens. So women with breast cancer are treated with Herceptin if their tumors express this HER2 antigen. Cetuximab is used in colorectal cancer, bevacizumab in a whole range of cancers, so cancers that express a lot of vascular growth factors. So some cancers are particularly vascular. So for example, kidney cancer that I treat is specific. It's one of the cancers that's the most sort of vascular. So surgeons are always really not scared to operate, but they always want to embolize the tumor first, because the moment you cut through the tumor surface, it's just an extremely bloody tumor because of the blood vessel formation. And that is all thanks to the overexpression of this vascular growth factor, VEGF. So this treatment of sort of targeting vascular growth factor with either antibody or a targeted therapy has been very successful in some tumors. We use a lot of antibodies in hematological malignancies, such as rituximab, and there's a whole range of others. And that has been successful over the years. We use it, it's a standard treatment, but it's not a cure. You know, we use it. In fact, a lot of the time, bevacizumab, the moment the cancer is controlled for as long as you carry on with the treatment, the moment you stop it, progression occurs. And the problem is that, you know, one would say, well, why don't we carry on? Well, we could do, but it's about £2,000 a month on average, if not more. So enormous amount of resources, side effects as well. So it's not really a good solution. So the true revolution came really from those two scientists. In 2018, there was a Nobel Prize awarded to James Allison and Tasuku Honjo in Japan, who both work on the same way of targeting immune system. The trials and sort of clinical experiments with those particular treatments go back much further. It's really only that this was appreciated and awarded 2 years ago. And this is the treatment that has really caused a revolution. So this complicated graph, it really, I only show it just to explain to you how it works and where that concept came from. So those two people and you know the whole army of scientists have been working over the years on inhibiting and disinhibiting the immune system. So our own bodies have a way of regulating the immune system so it doesn't get overactive. If it gets overactive, we get autoimmune disease. So we get rheumatoid arthritis, Crohn's, you know, all sorts of other conditions which have to be treated by dampening the immune system response. This inhibition happens thanks to certain receptors on the T cells and sort of antigen presenting cells. And those receptors are called PD-1, which is programmed death molecule, PD-L1, which is programmed death molecule ligand, CTLA-4. Those molecules, what happens in the immune activation is that those molecules which are expressed on the T cells, on the antigen presenting cells, become activated, but then very quickly become sort of saturated. So for example, a tumor cell that will be in contact with a T cell, then the ligand connects with the receptor, and that T cell has sort of becomes deactivated again. It's done its job, becomes deactivated, and the immune system sort of goes back to the regulated state. A little bit like, you know, what happens during a viral infection. We get a virus, the immune system gets activated, fights the virus, and then goes back down to sleep. Now, what they've done and what they've discovered is that if you use an antibody that blocks those particular receptors, so whether it's a PD-1 or PD-L1 or a CTLA-4, what you can achieve is the state of constant overactivation. So your immune system goes up like in the viral infection and never goes back down. So it always stays overactivated, and that can kill the tumors. And really that's where, you know, the whole concept of fighting the cancer and hopefully curing it comes from. And this is just an example of the pivotal study that was published many years ago now, 10 years ago, looking at treatment of melanoma. So the original study was with a drug called ipilimumab, which is anti-CTLA-4 inhibitor in combination with this peptide vaccine called GP100, and then the combination of the two. So the light green here is the peptide vaccine, which essentially was as a placebo. It hardly showed any activity. And you can see that there was a much better result in patients treated with ipilimumab and the combination of ipilimumab and GP100. And this may not seem a lot to you because it is only sort of 30%. But you have to remember that for years, we only dealt with this. So we were looking at 5% or less of patients who would be alive after 3 years. Now, this first drug, when it was used, we were looking at 20% of patients that were alive after 3 years. And this really has started, you know, a huge amount of clinical trials. So these are just some of the examples of the trials that started coming in. So, for example, non-small cell lung cancer, you can see the difference between those lines much bigger here now. So this was a chemotherapy combination, and this was an immunotherapy combination. Similarly, urothelial cancer, so bladder cancer, ureteric cancer, again, we can see everywhere that the immunotherapy effect was much bigger. Kidney cancer, in small print, it doesn't look very big, that difference, but believe me, it's there. So that was already, you know, a great achievement and real excitement for everybody. But if you look at the response rates in those cancers, they're still not good enough. So melanoma, for example, overall response rate was 33%, lung cancer 19%, kidney cancer 25%. So there's still, you know, less patients respond than not respond. So majority of the patients didn't respond. So the next step, as you can imagine, would be combination of various types of immunotherapy. And as time went on, we started seeing a lot better results. So this is, for example, combining the two modalities of immunotherapy. So ipilimumab, which is being an anti-CTLA-4 antibody, and nivolumab, which is the anti-PD-1. So if you remember from that graph, there were two types of the inhibitory or checkpoints, and if you inhibit both of them at different types of cells and different, you know, different points, then that response is much higher. So all of a sudden we've got, so this is comparison of nivolumab on its own or nivolumab and ipilimumab, and you can see the difference is massive. So this is progression-free survival, this is overall survival. So we're now looking at 2 years, 70% of patients being alive. Now these studies have now been published many years since, and we now know that close to 50% of patients are alive at 5 years. I mean, you know, these are things that you've never imagined. I mean, I certainly, you know, starting during my early career as an oncologist, never imagined that this would be possible. So really advanced metastatic cancer could respond like that to treatment. This is another example. So combination of pembrolizumab, which is another type of anti-PD-1 antibody, and a sort of placebo combination, you can see big difference. And again, we're looking at 2 years, close to 70% of patients alive. So, you know, much better results. This is a graph that just shows you that the way this treatment works is not the same as what we used to in chemotherapy. So with chemotherapy, as you know, we give the course of treatment, then stop it, and you achieve the response there and then. So if the chemotherapy works and you achieve a partial response, that's great. With immunotherapy, you give the treatment and you can watch the response developing over the years, because this treatment, for example, the combination of ipilimumab and nivolumab is given for 4 cycles only. There's 4 cycles of treatment, is 12 weeks only. And then after that, you often have the maintenance of only one of the drugs. But if you look at the figures here, you've got a response. So this is one of the original studies for melanoma, where you had the combination of ipilimumab and nivolumab. After 9 months, we had 11% achieving 11% of patients achieving complete response. After 36 months, so that's 3 years, that went up to 20. So, you know, they would have finished treatment ages ago. After 5 years, that went up to 22%. So it's not the drug itself. The drug has sort of upregulated your immune system to fight the cancer, and that sort of carried on working over the years. Similar, this is nivolumab on its own in melanoma. So even, you know, with a single drug, you can see that those rates are increasing. This is renal cell cancer, lower numbers, but still increasing over years. This is 3 months. And then you've got the last example here as well. So the big question is, why is it that only some cancers can be treated, or some cancers respond? So I mean, even, you know, if we reach 50%, why is it only 50% and not 100%? And does it mean that it's going to work for all the cancers? So there's a lot of science behind it, and a lot of questions asked, and some of them are being answered. So one of the ones that it's important to know is that the reason why some tumors respond to the treatment is that only some of those are sort of susceptible to immunotherapy. And if you can remember this very early graph that I showed you on the immunotherapy cycle, a lot depends on the number of antigens within the tumor. So if you have a tumor that has a lot of mutations, a lot of antigens, it's very heterogeneous, which traditionally it would mean it will do worse because the chemotherapy wouldn't necessarily work in the tumor like that. In immunotherapy, it means it's likely to do better because you've got so many different targets that the immune system can focus on that it's likely to do better as a result of that. So this graph shows you the sort of average number of mutations or so-called mutational landscape within the tumor. And it shows you the tumors that are most susceptible to immunotherapy. So for example, melanoma being one of the ones that where it works the best, lung cancer, so this is a squamous cell, and adenocarcinoma, again, it does very well. Bladder cancer, esophageal cancer, colorectal cancer. Colorectal cancer is only certain types. So colorectal cancer generally is thought to be quite poor in terms of the number of immunogens or the antigens that can be recognized by the immune system. But there is a certain subset called MSI high, which means that it has a bit more instability, genetic instability. And this tumor can be very susceptible to immunotherapy. Kidney cancer, but then you will see as we go along, some other types of tumors are very poor in terms of the number of antigens that can be recognized, and they will not do as well as some of the other tumors. So, you know, this essentially is an answer to the question who benefits from immunotherapy. So the tumors that have a lot more neoantigens and a sort of higher mutation burden, that have more expression of these receptors on the surface, although the number of receptors being expressed on the surface doesn't always correlate with the response. But these are the tumors that are likely to respond to immunotherapy. The tumors that are so-called poorer genetically, have less mutations, less PD-1 expressions, they will respond worse. This picture, I'm sure Piotr is laughing because it's shown all over the world on probably, you know, in the last few years in pretty much every immunotherapy lecture, because it is just stunning. Sorry, I'm just going to go up. It's malignant melanoma, looking really horrible. You know, 10 years ago, this patient would have died very quickly because nothing works on those tumors. Radiotherapy doesn't work, chemotherapy doesn't work. This is a picture after treatment with ipilimumab, and you've got week 16, so sort of 4 months, lots of horrible looking lesions that are ulcerating and continue to grow. After ipilimumab, the interesting thing is that you get this sort of pseudo progression. So you get increase of the size of some of the tumors, and that's because of the very active immune response and tracking of the immune cells into the tumor. So they actually, you get swelling of the tumors and they get bigger. But then from 12 weeks onwards, it's all starting to gradually improve. And this is sort of later on, sorry. So this is week 16, week 72, and week 108. So now we're talking about 2 years after treatment. Oops. Sorry, something's just happened here. There we go. And this patient has been in remission since. Sorry, I think these are links. Now, this is a similar picture, but looking at liver disease. So the top panel, panel A, you see multiple metastases. This is after immunotherapy, sort of 3 months after immunotherapy, where you can see worsening of the response. And this is several months, 2 years after immunotherapy, where you can see improvement. You know, you may argue that this isn't exactly improvement, but there certainly is improvement comparing to this pseudo progression here. And the fact that the patient's still alive, that is an improvement in itself. This is looking at that little, well, big really, lesion infiltrating the rib and the vertebra here, which has improved after a year of immunotherapy, but then unfortunately does come back. So, you know, it's good treatment, but there continue to be a lot of questions that are unanswered. And, you know, some patients will respond to immunotherapy initially, but then progress after that. This is a graph which is a little bit old now, probably 2 years old, but I really like to show it because it just gives you an idea of what's going on in oncology. So this was presented at the one of the conferences 2 years ago, and it shows you the number of clinical trials in cancer looking at different immunotherapy agents. So here on the side, you've got the different cancers that are being tested. So, you know, the whole sort of array of solid tumors, and these are all different clinical trials. So incredible amount of activity. There's, you know, the different companies that make those antibodies. There are different targets now, so not just PD-1 and CTLA-4, but a whole range of other checkpoints. And you know, this is an exciting life of oncologists and trialists, I suppose. And this is a bit more up to date. So as you can see, the new phase of the immunotherapy is trying to do the combinations. So combinations with sort of new targeted therapy, combinations with chemotherapy, combinations with other types of checkpoint inhibitors. So hopefully, as time goes on, we will see those responses a lot more sustainable and a lot longer. So it's all exciting. It's all sort of, you could say, you know, we're treating the cancer, perhaps curing quite a number of patients. So it's all good news. And as always in cancer treatment and any sort of new drugs, it's not quite the end of the story, because the biggest issue now is managing the side effects, and the side effects of those treatments can be horrendous. So as you can remember from what I've just, when I was talking about the activating the immune system, one of the main problems with those drugs is that once they work and your immune system goes into the sort of high level of activity, we develop autoimmune disease. And patients develop autoimmune disease. So as a result of this autoimmunity, you release this whole new, you know, army of autoreactive T cells. You generate, many of us have this sort of pre-existing autoreactive antibodies. And if the immune system becomes overactivated, those antibodies are being all of a sudden multiplied. Many of the antigens that cancer expresses are also shared by the normal tissue. So there are very few actually cancer-specific antigens, like PSA is a cancer-specific antigen. Vast majority of the antigens that are on tumor are also present on other tissues. So if you develop the immune cells that target a particular antigen, which is also present in normal tissue, you'll end up with, killing the cancer, but also destroying the normal tissue. So, you know, as oncologists, and Piotr will probably agree with that, is that, it's all been very, very exciting for us in terms of the new opportunities, but it's been really, really scary, because this whole new range of side effects. I mean, we've been treating cancer for years, and, side effects of chemotherapy, radiotherapy, they can be very severe, but they're very well managed. We're very familiar with that. I mean, they can still be life-threatening. People can still get life-threatening sepsis from neutropenia from chemotherapy, or severe side effects of radiotherapy, but it's all manageable. We do know how to manage that. With this came the whole range of new side effects that I have to say we really struggle to manage, and that's those of you who are endocrinologists or gastroenterologists, you will know that without sort of the help of all other medical specialties, this is going to be very difficult because of the complexities of the autoimmune disease. So this is what can happen. Patients can develop very severe dermatitis, they can develop Stevens-Johnson syndrome, they can develop terrible colitis. And when this treatment first came in, there are people who actually died from colitis because it developed in a similar way as you get in cholera, such profound diarrhea that patients got dehydrated rapidly, and it was impossible to keep up with their sort of fluid balance, and people died as a result of diarrhea. You can get any organ problems. You can get pneumonitis, myocarditis, hepatitis, pancreatic problems, nephritis. Endocrinologists have their hands full now with us because of the various endocrine complications. Whether it's everybody gets thyroid problems. That's an understood thing. But there's also a bit more complex conditions such as hypophysitis or diabetes. I know some of my colleagues have been very excited because they were involved in treating patients diagnosed with type 1 diabetes at the age of 70, for example. So, you know, things that were not seen before. That type 1 diabetes, it's you know, this disease diagnosed in young people. Now, as a result of immunotherapy, we can see it in much older people. Again, just the same slide really, but just showing you some additional side effects of various ocular complications such as uveitis, iritis. So, you know, it requires a real sort of vigilance to make sure that those patients are treated very early. These are all treatable conditions, and the way we treat it is by an antidote to an overactive immune system, which is very high dose of steroids. And it's not enough to just give oral prednisolone. They have to get intravenous steroids, and it's a very long time of weaning them off the steroids. So sometimes we go into, you know, 5, 6, 7 weeks of this sort of slow weaning patients off the steroids. The moment you stop it, the diarrhea comes back. So it really makes it quite difficult, but it is, you know, it's reversible, and patients need to be aware of that, that when they start the treatment, if they have a combination immunotherapy, so the combination of CTLA-4 and PD-1, we're looking at 50% rate of patients with autoimmune disease. The PD-1 antibodies are a little bit easier, it's only about 10%. But, you know, in some patients that may not be enough in terms of the activation of the immune system.
Hang on, those are they not
But,
on the shelf? What
so this is just a slide to show you, which I borrowed from BMS, just to show you
new ones.
The onset of median time to onset of those side effects. Okay. Sorry, I just need to unmute yourself.
Yeah, you are muted. Yeah,
Yeah.
something
Okay.
started happening. It's fine now. It's back to normal. You can carry on. Thank you.
Okay. So this is just a slide showing you an additional complexity in managing those side effects. So it's not just the severity and the type of the side effects, but also the time of onset of this immune or autoimmune complications. So this is a median time of onset, looking at, for example, rash. So on average, it happens after 1.4 months. But as you can see, the range here, it goes up to 17 months. So, you know, we'll give the treatment 1 year and you get the rash a year later because of your, you know, autoimmune reaction that took a year to develop. Similarly, immune-related diarrhea or colitis, on average, it happens within, you know, 1.4 months, but in fact, it can come up to 20 months later. So you could get the severe colitis from the treatment 2 years ago, or immune-related endocrinopathies. On average, it takes about 3 months, but again, it can happen much, much later. So, you know, all of those side effects can happen at a very late stage. So patients, those long-term survivors, you know, although they better, we still have to be very vigilant in terms of what can happen. And, you know, it's really important for everybody to know about it and the GPs, because in oncology, once the patient's well, then you know, the follow-up may not necessarily be every month, because it's just not possible to see everybody every month. So we might see them every 3 months. Now, in the meantime, they get this autoimmune complication. So whenever we start this treatment, we make sure that patients are well aware of the potential side effects, the complications. They've got the cards, they've got the telephone numbers, but you know, not everyone is as a vigilant person to sort of be aware and think about this. And when those treatments first sort of came in and started, and even now, to be honest, when they end up in A&E somewhere where there is no oncology center, where the clinicians are not familiar with those side effects, you know, they come up with a slight mild diarrhea, they're sent home. 2 days later, they come up with such severe colitis that it's really difficult to manage. And you know, if they came to an oncology center or had a contact with a clinician who was familiar with those side effects and was started steroids, that can be resolved within, you know, a couple of days, really. And this is, again, just a slightly different slide showing a median time to resolution. So the previous one was the median time of onset. This is time to resolution. So just to show you that some of those side effects are chronic or pretty much persistent. So endocrinopathies, for example, are pretty much permanent. So once patients become hypothyroid, they're hypothyroid for life. Some of the others, so for example, rash can resolve, but it'll take many months, up to 113 weeks or 2 or 3 years. Similarly, diarrhea, on average, it's a little bit easier, but it can last for again, close to 2 years, or pneumonitis, for example. So, real complexity and difficult complications to manage. So these are current indications for immunotherapy in UK, increasing list, increasing number of treatments. I mean, these are ones just approved by NICE, but there'll be some cancers where we've got, cancer drug funding, or for example, so-called compassionate access through companies. So there'll be a lot more. So melanoma, non-small cell lung cancer, kidney cancer, bladder cancer, head and neck, triple negative breast cancer, endometrial cancer, cervix cancer. So these are not quite there yet, not approved by NICE, but they're coming onto cancer drug fund already. So, soon we may be in a situation that pretty much every cancer patient will have at some stage access or contact with one of those new agents. And as clinicians from who come as a first point of contact, not oncologists, I think it's really important that we're all aware that some of those complications can be a result of autoimmune disease, and it can be a result of treatment that the patient received a number of years ago. How do we manage those new side effects? Well, there's obviously a new set of guidelines. They're published in every cancer center and various sort of support websites. We have to work with other specialties. So we're now starting, I think, in quite a lot of hospitals, they're now sort of combined endocrinology clinic, dermatology clinics, gastroenterologists are good friends, because of, we have to do colonoscopies on many patients who develop diarrhea. We need to share best practice and sort of educational materials, experience, and of course, teaching the patients, because without the patient telling us that they have problems, we won't be able to manage that. Somebody once asked, or many people asked, so is immunotherapy going to replace the chemotherapy and radiotherapy? There was a time when we went to the conferences maybe 2 years ago where you'd go to a talk and they said, chemotherapy, what? Because every single talk was just about immunotherapy. So, people almost lost interest. We're now learning that this isn't going to be the case, because we're likely to be using those two modalities of treatment in combination. We still don't have sort of effective biomarkers to say who is going to benefit. So a lot of the time we give it to patients, even if they then don't benefit, because we don't know who's going to do that. We know that not every tumor responds to immunotherapy, so therefore they will still need chemotherapy, radiotherapy. But personally, I think we are closer to curing cancer, and I wonder whether that's what you, after hearing this talk, think as well. So I'd be really keen to hear whether I managed to convince you. Thank you.
Super, dziękuję bardzo. Bardzo niezwykły i ciekawy wykład. Jakbyś mogła już zatrzymać szerowanie, sharing. Tak będzie, widzimy. Świetnie. Ja chciałem tylko powiedzieć, że tak jak Agnieszka mówiła, jesteśmy bardzo ciekawi pytań i tego, co teraz, jak rozwinie się nasza dyskusja. Ja tylko jeśli mógłbym poprosić, jeżeli ktoś chciałby zabrać głos, to oczywiście bardzo zachęcamy, tylko jakby mogła się każda osoba przedstawić, powiedzieć imię, nazwisko, i to by nam też ułatwiało mi tutaj ustawianie spotlighta na tą osobę. Oczywiście, jeżeli ktoś ma włączoną kamerę, jeżeli nie, to nie masz takiego konieczności, ale to byłoby fajnie, jakbyśmy się też łatwiej rozpoznawali. I druga jeszcze taka organizacyjna informacja, jeżeli ktoś z Państwa z jakiegoś powodu chciałby mieć certyfikat od nas, od związku, że w tym wykładzie uczestniczył dla swojego na przykład appraisalu, to mamy takie certyfikaty przygotowane. Jeśli mógłbym poprosić, to na czacie teraz tu na spotkaniu, jeśli ktoś by chciał, to proszę napisać swoje imię, nazwisko, e-maila, adres e-mailowy, i ja takie certyfikaty wyślę do wszystkich chętnych. Także to tylko takie dwie informacje. Jeszcze będzie kilka na końcu, ale na razie tyle i zapraszamy do pytań. Piotr jest
Właśnie
na
chciałam
pewno
poprosić
pierwszy.
Piotra o komentarz, bo ty też przecież używasz dużo immunoterapii.
Yeah, no, bardzo ciekawy wykład. So, yeah, I thought that was an excellent overview. I was just thinking, obviously, I'm a believer that immunotherapy is going to cure cancer, or most cancers eventually, once we understand the intricacies. But just coming back to the different types of vaccines, I was wondering, it didn't come up on your slide, and it's very topical at the moment, obviously, because of coronavirus, is the Pfizer BioNTech approach, because of course BioNTech was set up by 2 oncologists in Germany, and they're going for this mRNA approach, and they've been doing that for 20 years or so. And I know when they listed in New York on their IPO at the end of last year, there was very lukewarm interest. Their share price was only about $10 or so, and then as soon as they switched the company to coronavirus vaccination, it shot up to $110. So there's obviously still a lot of skepticism about vaccinations per se for cancer. Obviously, we have checkpoint, but what do you think? You did your PhD on cancer immunotherapy. These specific vaccines for cancer. Obviously, we have very good preventative ones for cervical cancer, probably the best example. But where do you see that? Are you as optimistic as BioNTech that mRNA vaccines are going to be the future? Be very interested in your view on that. And the second one, I just wanted, if you could elaborate a bit on your views on immunotherapy in ovarian cancer, because of course that's one of your areas of interest. Then, I think there was a paper this year on Ipi/Nivo showing some few responses, but the majority of patients are not responding. So where do you view immunotherapy, particularly in these more refractory tumors such as ovarian cancer?
So mRNA vaccines, I suppose, yes, it's difficult. I mean, when you actually read about how they measured the response in the Pfizer study, it's really questionable, why they say that it's going to be 90% or 95% efficacy. So far, out of these thousands of patients that received the vaccine, 100 patients have then got infected with the virus, and 90% of them had very few symptoms. Now, we don't know that yet, but actually out of 100 patients who weren't vaccinated, you'll probably find that 80% will have no symptoms at all at the moment, because majority of people are asymptomatic. So I'd be a little bit skeptical that the 90% efficacy is actually a true reading. I know it's not enough time and not enough people, and that's the best way they can measure it statistically. But with this particular virus, we know that quite a lot of people have an asymptomatic course of disease anyway. So whether it is the mRNA vaccine that's caused it, I know of another study where the mRNA vaccines are being used, and we'll just have to wait until the results are known. But it's not been very impressive.
We'll need to see what happens with the viral strategy, but obviously they're using that as a template to then go back, I think, into oncology. That's actually, I heard an interview with one of the CEOs of the company that, they've raised a lot of money, and their idea is to go back eventually to cancer and use the same mRNA approach. They're using the current pandemic as a testing ground. But what's your view on that mRNA specific approach as a cancer vaccine? Do you think that has traction?
Well, I think it certainly has some, there's a good rationale behind it, isn't it? It's the worrying thing is, the mRNA is meant to work by sort of getting our own cells to produce the particular genetic, DNA and then protein that they want to program. So I can't see why that would be less effective than, for example, DNA vaccines. That, I think that the whole concept is good and it might work. But the vaccines, as you know yourself, are not a very potent stimulant. So they may work well with checkpoint inhibitors. So if you combine it with something and then introduce additional antigens and sort of make the novel response of the immune system to those antigens, they may work. But you wouldn't use it by itself.
Yeah, but even in the melanoma, the very first slide you showed on the study of ipilimumab, the GP100 had absolutely no effect. It was really the ipilimumab. So, I'm still looking for a study that actually shows that this specific tumor peptide or mRNA is actually going to work. So I still remain a bit of a skeptic on that, but certainly the checkpoint is the main driver. So what's your view on ovarian cancer immunotherapy?
Yeah, so ovarian cancer is it's a difficult one, and it's been a great disappointment to all of us that the checkpoints haven't been more effective. All the studies showed a maximum of sort of 10-12% response rate with the checkpoints, and I think it's despite having, there are certain types of cancers where you will see a lot of tumor infiltrating lymphocytes and a lot of sort of immune activity, but vast majority of them have this poor sort of mutational landscapes. They're just not very, they don't have very good antigens to be picked up by the immune system. So there are trials ongoing, and in fact, we're going to have another one in combination with PARP inhibitors with ipilimumab and nivolumab now, but all the studies so far showed a very poor response, so 10 to 12%. So in fact, uterine and cervix cancer will be a lot more responsive to immunotherapy than ovarian cancer, which is a great shame.
Okay, thank you very much.
Hello, may I ask a question?
Of course.
Tutaj Bartkiewicz Adam się kłania. Jestem GP Gerrard's Cross Chalfont St. Peter. Również jestem alergolikiem, allergologist. Po angielsku zadam pytanie, jeżeli można. Now, as an allergologist, we can actually do sublingual immunotherapy to counteract allergic phenomena. That is allowed, and it's quite safe to actually do in general practice. Now, Dr. Michael, what do you think about doing such immunotherapy in general practice in the future? If it's possible, when do you think it will actually come online?
Well, I don't know. That's a simple question. So when you do immunotherapy sublingually, what is it that you actually give the patient?
Well, it's very, very small doses of something, let's say, like grass pollen. I mean, Grazax is the prime example. Obviously, I know from my American colleagues in family medicine, they actually give sublingual immunotherapy for other allergens. For example, animal dander like cat, dog, etc. So I think the field is quite wide in America, a little bit more restricted in the United Kingdom. But I mean, grass, just small doses of grass on a fairly regular basis. Obviously, there's a huge time lag for response. We're looking at treatment cycles of about 3 years or so. Patient has to attend, every month to 3 months or so. So it's quite time intensive, but it works.
So it's desensitizing patients essentially, isn't it? So it's exposing them to more antigen. So I mean, I think the equivalent of that in cancer would be giving the additional vaccine. So essentially increasing the number of antigens. So the whole cell vaccines, so DNA or the RNA vaccines, would be adding the additional antigen to give more of a load of antigen to desensitize, or not to desensitize, but to build up the immune response. An interesting concept. I don't necessarily think that's going to take off in oncology, but I suppose, I didn't think that we would have this type of treatment 10 years ago. So there you go. We'll wait and see.
I suppose anything's possible, but certainly in my lifetime, probably not then, which means that my workload won't increase any more than it already has done. Thank you very much.
I would just add to what Adam's just said, is that there are developments in oral checkpoint inhibitors. So they're trialing tablet versions of these antibodies. I don't understand the chemistry and whether I think it's quite difficult to do, but that may be coming in the future. But whether that's going to be available in general practice, I don't know.
Interesting. Thank you.
Jest pytanie od Martiny tutaj na czacie. Martyna, jakbyś po prostu włączyła się i zadała, byłoby super.
Tak, dzień dobry. Ja nazywam się Martyna Leczycka, jestem junior doctor at Charing Cross. Akurat też pracuję na onkologii i to jest takie trochę divided opinion, jeśli chodzi o revaccinating young females and males with the new Gardasil vaccine after having received it as a teenager with a 3-valent version of it. What is your opinion about it?
I mean, my general opinion is that everybody should have it because, you know, if the vaccines are good for something, it's preventable cancers. So if we can prevent, you know, if we can vaccinate against cancers that are driven by HPV, then we should do that. I can't really comment on different types of vaccines because I don't know enough about it. But you know, I think I certainly would advise every teenager in this country to have it because you know, if we can eliminate at least one type of cancer, and I think the boys should also get it because of the head and neck cancers, then we should.
But so do you think that we should revaccinate it? So if they have received the 3-valent vaccine, they should now receive the 9-valent vaccine?
I'm not sure about that. I mean, I think the 9-1 just contains more antigens, doesn't it?
Yes.
Yeah. So it's, you know, it's a question mark because as you probably know, those vaccines have to be given very early on. So before any potential contact with an antigen in real life. So, you know, for example, before sexual intercourse. So you don't have the virus introduction after the vaccine. I mean, so you have it after the vaccine and not before the vaccine. So, you know, if you now go and give them a much more potent vaccine with new antigens, but people have already had contact with that virus, it may not necessarily be effective. So I think we just don't know enough about it. I think, you know, further studies need to follow. Yeah.
Thank you.
No jeszcze na pewno ktoś ma ochotę zadać pytanie. Ja mam jedno, ale jeszcze na pewno ktoś ma ochotę.
Ja mam. W razie. Tu Ewa Lichterowicz-Kryńska, jestem pediatrą. Właśnie chciałam się zapytać na temat immunotherapy and pediatrics. The other question that I really wanted to pose, or the other observation really, is that the presentation of the endocrinopathies is rather quick after the immunotherapy has actually been started in the adult patients, and therefore the pathophysiology of the endocrinopathies is quite different in the way that they evolve after the immunotherapy. I was just wondering whether you knew from your endocrine colleagues as to how the presentations differ, and clearly they must be particularly overwhelming because in childhood diabetes it takes on average 22 to 23 months from appearance of antibodies for the clinical manifestations of diabetes to come through, whereas here you're talking of a much shorter period and presumably a much more overwhelming type of presentation.
So in terms of the difference between adults and children, I don't know. I just wonder if there is Agnieszka Falińska perhaps online. She's an endocrinologist that she works with us on managing those side effects, but I don't think she's in.
Jestem. Zaraz tutaj spod światło siedzę momencie.
You want to comment on that?
Well, not really. I think from what I know about, for example, diabetes, is that it's lots of research done. I think there was a paper published in Lancet, but I don't know why it's happening so quick. So that's the answer. I think it's something that maybe we can do research together, Agnieszka, why it's happening so quick. But I don't think I know the answer why, because it is true that, I mean, thyroid particularly, but also type 1 diabetes, we had this patient together that developed quite quickly.
It will be a different antibody response, a different mechanism, different pathway,
It
and
will be a
therefore
different
complete
exactly.
destruction of the cells.
It will be a different mechanism. It's not so they were negative for the islet cells and gut antibodies, these patients. So it is completely different mechanism. But why it's so much quicker, I don't know.
I know that with thyroid, what we see is indeed a very quick response. So what normally happens is after the first or second injection, they all get this sort of thyroiditis and very high level of TSH, which then just all burns out and they all get hypothyroid. Diabetes, you know, I leave it to the endocrinologist.
Okay. Thank you.
I just perhaps wanted to touch on the side effects issue, Agnieszka. So with ipilimumab and nivolumab, you're probably seeing also, you know, multi-syndromic patterns of autoimmune disease. I've certainly had a couple of patients who diagnostically very difficult. I mean, it's almost as if oncologists are becoming more and more as generalists and intensivists, because one patient not so long ago I treated with mesothelioma ended up having 3 side effects: Addison's, so his adrenal shutdown, about the same time as he developed and was admitted to a stroke unit for a presumed stroke, which actually was encephalitis due to the immunotherapy. And then afterwards, when we did a CT scan, once his Addison's and encephalitis settled down, which encephalitis has a very high mortality anyway, he then had evidence of pneumonitis on his CT scan as well. So, you know, he responded to, I think he had 2 mg per kilogram of methylpred on a very slow taper. But certainly, I think, you know, with more use of combinations, I think we're going to be seeing more and more of these multi-syndromic presentations. Pardon?
Have you cured him?
He responded, but sadly, about 6 to 8 months later, the tumor progressed and he died earlier this year, actually. But some of the patients who have a lot of these side effects, you know, there's that saying, no gain without pain. And certainly some patients who go through a lot of side effects end up getting very durable responses. So one patient we published a few years ago with uveal melanoma with multiple liver metastases, about 20, he had 5 side effects, including type 1 diabetes. So he presented to a DGH with, you know, diabetic coma with sugars over 40. And then he twisted my arm to carry on after he recovered from that with with nivolumab. So he had 3 months. He was already, his LDH had gone from 6,000 to normal in the space of 50 days. That's how quickly the anti-tumor response manifested. And then, so I gave him 2 shots more of nivolumab after the ipi-nivo, and he then developed complete blindness because he got uveitis in his only good eye, having had the other one destroyed with protons from his uveal melanoma. So the only side effect he has at the moment is occasionally, so he's on insulin for the diabetes now. He's in his 4th year now, having had 20 liver metastases. So, you know, he's got a very durable response, but he still gets a bit of skin psoriasis, and he needs to take 1 steroid eye drop in his eye 4 years later, because if he doesn't, the uveitis, his headache starts coming back and he starts getting visual problems. So he's under Morphields for that. So he's on basically insulin 3 times a day and 1 steroid eye drop in his eye. So, you know, I'd be interested to know, you know, your experience of these sort of patterns, whether you're
I'm pleased to say
that as
I've
well.
not had that experience, and I'm hoping not get it.
But you're using ipi-nivo in renal, right?
Yeah.
And the dose is, I think,
it's 1 milligram.
It's important to say that it's a smaller dose of ipilimumab. Certainly in melanoma, you're using 3 times that dose, and it's really the ipilimumab that's driving a lot of these additional side effects. But I think, you know, people generally should be aware that these drugs can cause more than one type of side effect. And you know, your slide was very useful with the timelines. I think I treated one patient with steroids for a year for hepatitis before the hepatitis resolved. You know, very, very slow steroid taper. But that person is looks as if they're cured from melanoma. That was a few years ago, with widely disseminated cutaneous melanoma.
One thing that I haven't mentioned, which again may be a topic maybe for another time discussion, it's about the microbiome, which I'm sure a lot of you are interested. Microbiome being the sort of bacterial culture that we have in our bodies, and that there is increasing evidence that depending on the microbiome, your immune response also is very important. So what's becoming more and more evident in oncology, for example, is that using the antibiotics, and I know that GPs are very good with antibiotics. We're not. We give antibiotics to everybody because, the general thing is that he's got cancer, he's more immunosuppressed, therefore antibiotics are given very freely. But what has been observed and reported in a number of studies is that those antibiotics often interfere with the microbiome in the colon and therefore impair the immune response to immunotherapy. So, in some centers, people are now really, really careful, and we're trying to be careful as well, not to overdo the sort of antibiotic treatment, because it may in fact impair their response to cancer from their immunotherapy treatment. But that's a topic in itself, isn't it? So maybe we could find a speaker to talk to us about microbiome. That would be really fascinating.
Agnieszka, thank you very much for choosing immunotherapy as a topic, because as you know, I'm a hematologist, but it is actually immunotherapy of cancer that I was doing as a student, and that's what brought me to oncology and hematology in my case. We started off by using interleukin-2 many years ago, and it's interesting to see that solid tumor oncology has gone mainly the checkpoint inhibitor currently. In hematology, we've been using a lot of adoptive immunotherapy like CAR T cells. So where do you see the role of CAR T in solid tumor currently?
Yeah, well, I mean, it's as effective as the checkpoints, isn't it? We don't have it approved anywhere as yet, but I know there are certain malignancies where this is now used as a standard, especially in pediatrics, I think, isn't it? And it would be too long a talk to put everything in, but it is fascinating. And from the side effects, what I see are pretty much the same as the checkpoint inhibitors, aren't they? So it's a very potent form of immunotherapy. Yeah, I think maybe that's for another talk from somebody one day.
Yeah, okay, but it's a great topic. Thank you very much, because what I was impressed with at the beginning of 90s, so some years ago, was the works of Steven Rosenberg when he was giving interleukin-2 and seeing responses in melanoma and renal cell cancer. Yeah. But thank you.
Proszę bardzo, proszę.
Oh, actually, I've got one more question. Very old-fashioned immunotherapy being BCG.
Yes.
Because that's come back to, recently.
We still use it. We still
use it, yeah.
We still use it, and whenever I give a lecture to sort of to students, to undergraduates, we always start from BCG. It's still a potent treatment of bladder cancer. A little bit based on the same principle as the colitoxins wasn't it? So treating a disease by inducing inflammatory response. But it does only work in bladder cancer. We have tried it in lung cancer and a number of others, and it wasn't a good enough response.
Well, it came back recently in the context of the pandemic, because which is quite interesting. So immune system is we still have to learn a lot about the immune system, I think.
Hello, can I answer a question? I'm not quite sure, not very good at it. Moje nazwisko jest Hanka Rakowicz. Przepraszam bardzo, to mam tutaj z rodzinami, zrobiła mama narodzinne spotkania i teraz dlatego jest mama. Jestem Hanka Rakowicz. Ja jestem, I'm a retired GP, and I wanted to ask a couple of questions. Sorry, have I butted into your discussion? Down to earth questions. is this treatment available anywhere? I live in Southeast London near King's. Not that it's pertinent to me. That's number one thing. And the other question I'd like to ask is, do you discuss all the pros and cons of the treatment with the patient? And I presume you do. Do you get many patients turning it down because of the risk of the side effects and things that go on afterwards?
So answer to the question, the first question is that yes, it is available everywhere within where the Cancer Drug Fund is available. Ipilimumab and nivolumab is extremely expensive. The course of 4 injections is £98,000, which NHS pays for. Nivolumab maintenance after that is about £4,000 a month, and that's for the drug alone. That doesn't include the chair time and the time of the nurses and etc., etc. So, but it is available for those cancers where there is good evidence that it works. So we do have the NICE guidelines and the Cancer Drug Fund inclusion criteria. In terms of the topic, discussing it with patients, we do discuss it, and I do have patients who are absolutely petrified of that, because they all get, you know, a printed information sheet will then list all the potential side effects. And, you know, I have had patients who said, no, they don't want to do it. If there are other options of treatment, they sometimes settle for the others, so for targeted therapy. But if there aren't, and you know, in some cancers, this is still the best option, people will just risk anything, because if they don't do anything, the outcome is known. If they do this, then, you know, they might be unlucky to get some side effects, but they'll be alive. So yes, but we do have very detailed discussions about the side effects.
Mm-hmm. What about age?
It's a tricky one, but we aim not to be ageist, and you know, nowadays it's the biological age and the physical and the sort of, you know, the calendar age, isn't it? And often those two don't necessarily overlap. And I do see a lot of, you know, where I work, I'm fortunate enough that in Surrey you just see a lot of very, very fit people who will, you know, come straight from the golf course regardless of, you know, the fact that they're 85 or 90, and yes, we do use it. I think I probably would worry about combined immunotherapy with the sort of ipilimumab and nivolumab, because they do have, you know, it has a higher incidence of side effects, but certainly single agent immunotherapy. And yes, and we do have additional discussion about COVID, because there is some evidence that immunotherapy can potentially make the course of the COVID infection worse because of this overactivation of the immune system, and that second phase of COVID infection where people become really ill and end up sometimes in ITU can in fact be made worse by immunotherapy.
Thank you.
Well, thank you very much, I think.
Jeszcze tak koniec bardzo szybko ode mnie, jeśli można, Agnieszka, to już na pewno ostatnie, mam nadzieję, chyba że jeszcze ktoś się w międzyczasie zastanowi i jeszcze zgłosi. Ja mam takie pytanie. Mnie jako GP najbardziej zmroziła ta informacja, że działania uboczne mogą pojawić się po 2 latach, wtedy gdy pacjent już nie jest pod kontrolą onkologa, mimo że gdzieś tam na początku leczenia, czy może i w trakcie i pod koniec miał powiedziane, że te takie i inne objawy mogą się pojawić i to będzie pewnie być może działanie uboczne, to może po 2 latach czy po jakimś czasie już tego nie pamiętać i pojawia się u mnie jako GP i nagle może zostać przeoczony prawdziwy powód, dlaczego na przykład ma biegunkę, tak jak wspomniałaś przykładowo. Czy są jakieś działania uboczne, które szczególnie częściej występują w szczególnego rodzaju leczeniu, na które trzeba uważać, i czy jest jakaś szansa, a być może to już się dzieje, tylko ja tego nie wiem, że GP są uczulani, że te inne działania uboczne u tego pacjenta po tym leczeniu należy uważać za możliwe działanie, czy takie objawy należy uważać za możliwe działania uboczne i wtedy z powrotem pacjenta skierować do onkologa, czy takie coś się dzieje może? Możesz po angielsku, proszę bardzo, ja tylko tak.
It's a very, very good question. And it's not an easy one to answer. So I think, you know, the early diarrhea is often the earliest immune complication, so that often happens much earlier. I think the endocrinopathies are the ones that are likely to, you know, to carry on, and they're pretty much permanent. So I think, you know, certainly endocrine complications and really the odd ones as well. So, you know, not just the thyroid or even diabetes, but the hypophysitis or you know, testosterone and things like that. So that's something that is likely to carry on for a long time. But it's, you know, in some ways we're still learning about it. You know, in melanoma, this treatment has been omnipresent for about 5 years, and kidney cancer for about 2 years. So there certainly are lectures for GPs, possibly not enough, you know, to sensitize people. I think at the moment we're all very aware of the potential complications ourselves. So we, you know, we keep all of those patients and follow up, and they're all aware that they can contact us, you know, at any time. So I don't think, you know, any of us would have discharged the patient as yet. But in the future, you know, those treatments may well come into so-called adjuvant settings, so post-curative surgery to decrease the number of relapses. And I think that's where the patients become eventually, we discharge them. So yes, I think we will have to think how to treat those, you know, treat it better in the community and make everyone aware. We're probably not very good at that at the moment.
Super, dziękuję bardzo. Czy jeszcze ktoś może?
Agnieszka, you've got
Agnieszka,
a microphone.
jesteś zamutowana, Agnieszka. Przepraszam, nie słuchać ciebie.
Ja chciałam właśnie taki komentarz powiedzieć, że są przecież te kliniki late effects, które są dla tych po tradycyjnym leczeniu. Więc myślę, że maybe in English in future we'll probably have late effects clinic for immunotherapies, when there would be some panels that we will be looking and checking for. I think that's probably would be the future. That's what I imagine. Agnieszka, what do you think?
Well, I hope so. I hope so. And they are, you know, they are starting. I think at the moment is not enough of them, and it's not enough provision. But hopefully, as you say, in the future there will be an easy access clinic where we will be able to send the patient straight to.
Can I just add that late effects clinics are something that we as pediatric endocrinologists are very involved in for peds, because clearly cranial irradiation and things like that can manifest with growth hormone insufficiency sort of even up to 2 years after treatment is finished in children. And so, and they're multidisciplinary clearly with psychologists, cognitive follow-up, endocrinopathies, growth and other subspecialties. And so maybe modeling that for adults would be very, very useful, as these things are happening more frequently now after immunotherapy.
Definitely.
Świetnie, dziękuję bardzo. To było bardzo ciekawe. Tu dużo komentarzy jest na czacie, że jest bardzo, bardzo jakby dobry odbiór twojego wykładu, Agnieszka, i wszyscy są bardzo zadowoleni, że mieli okazję cię posłuchać i zainspirowani. Ty już wyglądasz na dość zmęczoną, także, chociaż dalej wyglądasz pięknie, ale myślę, że już wystarczy i poproszę panią Bożenę może, żeby już powoli zakończała spotkanie. Potem będziemy mieli jeszcze taką uwagę jedną techniczną na temat następnego spotkania, które będzie 6 grudnia w niedzielę, ale najpierw pani Bożena. Ja panią już za chwileczkę. Trzeba się odmutować, pani Bożena jeszcze. Przycisnąć unmute. Gdzieś powinno być po lewej stronie na dole. Jest taki mały mikrofonik. O, teraz?
Już chyba teraz tak.
Teraz dobrze, tak, teraz dobrze.
Dobrze. Agnieszka, thank you ever so much for the most interesting lecture that I've learned an awful lot. It's all kind of past my time. Being on the surgical side, we just chopped them out, although we did do combination chemotherapy for our head and neck tumors. But all this immunotherapy is certainly very new and very, very interesting, and of course very hopeful for the future. So I'm really hopeful that this is something that will certainly help a lot of people having a very strong family history of neoplasia. To me, this is great hope. Agnieszko, dziękuję bardzo serdecznie od nas wszystkich i wszystkim również bardzo serdecznie dziękuję za wzięcie udziału w dzisiejszym naszym spotkaniu i no szkoda, że nie możemy się osobiście spotkać, ale przynajmniej na tym Zoomie niektóre twarze się pokazały też i też bardzo miło się zobaczyć, więc dlatego też zapraszam na nasze kolejne spotkanie, które już nie będzie takie bardzo intensywnie naukowe, będzie bardzo ciekawe i to jest quiz mikołajkowy, bo to akurat z samego Mikołaja wychodzi nam 6 grudnia, to jest niedziela i to dzięki właśnie tutaj Dorotce, gdzie jest Dorota, gdzieś była?
Jest Dorota, tak.
Tak, i z pomocą Martyny, właśnie naszej nowej członkini, więc to się zapowiada bardzo ciekawie i na to zapraszamy. A następne naukowe zebranie będzie właśnie w lutym i też się zapowiada bardzo ciekawie, więc na wszystko będą wysłane maile. I teraz właśnie poproszę jeszcze naszego sekretarza Tomka, któremu bardzo dziękuję za tą całą technologię, tutaj on potrafi to wszystko zorganizować. Więc za to dziękuję za dzisiaj i bardzo proszę, żebyś wytłumaczył nam właśnie te techniczne sprawy odnośnie tego quizu. Dziękuję wszystkim i do zobaczenia 6 grudnia.
Również dziękuję.
Dziękujemy bardzo i to dzisiaj znowu wyszło bardzo dobrze nam to wszystko i to jest bardzo pozytywnie wygląda na przyszłość, chociaż wiadomo, że spotkania takie realne czy fizyczne na pewno jeszcze atrakcyjniejsze są. Ja tylko 2 słowa na temat tego 6 grudnia, który już niedługo wyślemy na ten temat tego quizu. To jest quiz, będą pytania, odpowiedzi, mam nadzieję, że dobra zabawa. 6 grudnia o 18, czyli 6 po południu, to jest niedziela. I tylko wyślemy zaproszenia, na którym to będzie jeszcze, na które będzie to troszkę wytłumaczone dokładniej, ale chodzi o to, że na ten quiz będą potrzebne 2 urządzenia ze screenem, czy z ekranem, czyli jedno pytania będą zadawane na Zoomie, czyli tak jak teraz rozmawiamy, a potrzebny będzie drugi, najlepiej telefon albo iPad, na którym będzie można przycisnąć guzik i odpowiedzieć na pytanie, które będzie się pojawiło na Zoomie. Czyli to troszeczkę tylko skomplikowanie brzmi, ale tak naprawdę jest bardzo proste. Zrobimy kilka pytań takich na początku, żeby to przećwiczyć i rzeczywiście dzięki temu, że jest taka aplikacja, która synchronizuje zadawanie pytań dla wszystkich, na przykład w Zoom, i jednocześnie te wszystkie urządzenia mobilne, na których przyciska się przyciski i odpowiada na pytania, to tego rodzaju quiz naprawdę jest bardzo emocjonujący. Ja brałem w takich quizach udział kilka razy i to rzeczywiście wygląda bardzo fajnie, także bardzo serdecznie zapraszamy. W niedzielę na 18, 6 grudnia, jeszcze myślę, że w tym tygodniu wyślemy to osobne zaproszenie. Dobrze? No już tyle w takim razie. Dziękuję bardzo za dzisiaj. Bardzo miło było wszystkich zobaczyć. Wszystkiego dobrego. Udanej niedzieli wszystkim życzymy. Tak?
Dziękuję.
Dziękuję bardzo. Nawzajem.
Dziękujemy.